Hello, this is Michael Altos, and we are wrapping up our discussion of fundamentals of clinical pharmacology, and this is recording part 4. Up until now, we've been talking about pharmacokinetics, which is what the body does to the drug, how it's absorbed and transported and metabolized, the kinetics and the half-life, and all of those things are what the body does to the drug, but we haven't discussed the whole reason we give the drug, which is to do something to the body. And that's pharmacodynamics, what the drug does to the body. First, we need to define some terms. The first terms we'll define are the ED50, the effective dose or the therapeutic dose required to produce a specific effect in 50% of the population. This is kind of like MAC for an inhaled anesthetic. We compare this to the LD50, the dose required to cause death, the lethal dose. Or some people talk about a TD50, the toxic dose, in 50% of the population. Here we see some dose-response curves of a kind. On this axis we see dose, and actually these aren't normal dose-response curves. These curves are showing, they're really kind of like bell curves. They're showing as I increase the dose, what percentage of people are going to have the therapeutic effect, or the toxic effect, or the lethal effect. So I can see as I increase the dose, first nobody has an effect, and then more and more and more people until I get to the dose where 50% of people have an effect. And then the dose continues to increase until 100% of people have experienced the effect. The therapeutic index is the ratio of the LD to the ED50. It tells us the room for error. What's the difference between the safe dose and the unsafe dose? And the space between these two drugs is your therapeutic index. As these spaces get smaller and narrower, the drug becomes more difficult to titrate as the difference between the safe dose and the unsafe dose becomes very small. Let's look at a different form of this same graph. Here we again see the therapeutic dose and the lethal dose. And again, the therapeutic index is the space between these two doses. We can imagine them as traditional bell curves, where here's the range of population. So most people get an effect at the 50% dose. Some people don't get an effect until a higher dose. And fortunately, the lethal dose occurs at a much higher dose. But imagine if these two bell curves started to overlap. If the space between these two curves became more narrow, then we would have a more dangerous drug with a narrower therapeutic index. Just one other point I should mention. In anesthesia, our drugs have a two-tailed therapeutic index, which means not only is it dangerous to give too much drug, it can be dangerous to give too little drug also, because a patient could have awareness under anesthesia, for example. And this is actually true for several different kinds of drugs. And we'll actually hold off on the simulation for just another slide or two. The next concept we need to clarify is the receptor model. This is a very basic approach to receptor theory, and I just want to remind you of it. The idea is that we have a drug which binds to a receptor, and when the drug and the receptor bind, this leads to an effect. So we have X, which is an agonist, some sort of a drug that binds to a receptor and produces an effect. When X binds to the receptor, it leads to the effect. And most agonists bind reversibly. So they continuously can bind and unbind, bind and unbind. When they bind, they make the effect. And when they unbind, the effect goes away. But we should just remember that there are billions of drug receptor pairs continuously binding and unbinding thousands of times a second. And we're looking for the net effect of all of these billions of drug receptor pairs together, whether they're mostly bound or mostly unbound most of the time. Now, these are true dose-response curves, and you definitely need to know how to draw these and interpret them. On the x-axis, we have dose. On the y-axis, we have response. If you give no drug, obviously you have no response. As the dose increases, the patient's response increases as well. So they have more effect on their heart rate, or more deep sedation, or whatever your effect is going to be for that drug, until you get to a maximum efficacy, a maximum response, and you can't have any more response regardless of how much more drug you give. You might have more side effects, but you won't have any more of the response that you're interested in. So potency is simply how much drug you need to get an effect. How many milligrams of drug do I need to achieve something? And it usually has to do with the affinity for the receptor. So in this graph, we have drug X and drug Z. They can both achieve the same effect of, let's say, a response of 2. But drug Z needs like 20 or 30 milligrams. Drug X only needs a couple milligrams. These might be like morphine and Dilaudid, for example. They're both strong analgesic opioids, but one of them needs more milligrams than the other. So we say that drug X is more potent than drug Z. That's potency. Efficacy looks at the maximum degree of effect a drug can cause. So comparing drug X and drug Y, they both have pretty similar potencies, right? At a dose of 1, we're getting similar responses, but at some point drug Y maxes out its effect, but drug X can cause a greater effect. So we say that drug X has more efficacy than drug Y. We can also talk about a partial agonist. A partial agonist is a drug that produces a lower maximal response than a full agonist. So that is a drug that has, lower efficacy. So again, looking at X and Y, X could be a full agonist, Y could be a partial agonist. Interestingly, if you think about it, when drug Y binds to its receptor, it actually blocks drug X. So in a sense, a partial agonist is a little bit of an antagonist. It's blocking the ability of X to have a higher effect. These are very important concepts that will be tested, so you should be able to recognize and draw dose-response curves. Now let's take a look at the simulation. This is a dose-response curve. Again, this is not quite as S-shaped as what we saw before, but the same idea, that at 0 concentration you have 0 effect. And as you give more drug, you get more and more effect until you get to the maximum effect. Potency talks about how many milligrams do we need, what concentration in the blood do we need to achieve an effect. Drugs with less potency are shifted to the right. You need more concentration to achieve a certain effect. Drugs with high potency are shifted to the left. You need less concentration, less milligrams, in order to achieve your desired effect. Efficacy is the maximum effect that a drug can achieve. Here's a drug with low efficacy and with high efficacy. You can give more and more drug, but you won't be able to give more than the maximum efficacy. And finally, therapeutic index. Here we see a drug with looking at the desired effect. Here we see a drug looking at its adverse effect. Unfortunately, you need more drug to get the adverse effect than you need to get the desired effect. Suppose I decide to give someone this much drug right here. You can see I get a nice desired effect, but I will get a little bit of adverse effect, and this difference is the therapeutic index. Drugs that have a high therapeutic index are very safe because the dose needed to get an adverse effect is way past any dose I would use to get my desired effect. But some drugs have a very low therapeutic index, and the difference between the safe and the unsafe dose is very small. Redundancy is the concept that there's an excess of receptors. You don't need to bind 100% of your receptors to get the full effect of a drug. The maximum effect can occur at far below the maximum receptor binding. For example, your neuromuscular junction only needs about 25% of your receptors bound to acetylcholine in order to have full clinical strength. Incidentally, that's why people will tell you you need to block more than 75% of your receptors before you get clinical weakness. The body is designed to have redundancy, so that if you're missing a few receptors, if you don't have full acetylcholine binding to every receptor, you still have all of your strength. Tolerance means having a diminished response to a drug because of chronic exposure. This can happen due to some adaptation on the cellular level. It can happen because you've induced enzymes which change the metabolism of the drug, so the drug is metabolized more quickly. You could have neurotransmitters get depleted because you've continued to give a drug over and over again. Tachyphylaxis means acute tolerance after only a few doses. So an example might be your first dose of ephedrine bumps up the blood pressure by 30 points. But by the time you get to the 5th dose of ephedrine, it only bumps up the blood pressure by a couple points. So we talked about agonists. Our agonist drug X binding to a receptor and causing an effect. We also have antagonists, drugs that bind to the receptor but don't cause an effect. Most of our antagonists are competitive antagonists, which means just like the receptor can bind and release repeatedly over and over again, the antagonist can also bind and release over and over again. So if I give a drug like morphine, which binds to its receptor, and then I give an antagonist like Narcan, which binds to the receptor and causes no effect, can I make the morphine work? Sure I can. I just need to give even more of the agonist, and it will compete against the antagonist, and whichever one there's more of, and also considering each of their affinities for the receptor, we can compete against the antagonist and get an effect again. So what does an antagonist do? It decreases the potency of the agonist, but efficacy isn't changed. If I give enough drug, I can still achieve my maximum effect. So that's a competitive antagonist. Now let's talk about non-competitive antagonists. And those of you with a background in biochemistry may recognize that I'm oversimplifying this, but for our purposes, this is sufficient. A non-competitive antagonist could be a drug that binds to the receptor irreversibly. Or it could be a drug that binds to a separate binding site on the same receptor. Either way, what we'll find is that non-competitive antagonists reduce potency and efficacy, and it's possible that increasing our agonist dose of our original drug cannot completely overcome the action of this non-competitive antagonist. Let's take a look at the simulation. And we'll skip to the second module here. So here we see a dose-response curve. At 0 concentration, there's 0 effect, all the way up to the maximum effect, which is our efficacy. If I add a competitive antagonist, now I need more concentration of drug in order to achieve the same effect, because I'm competing against the competitive antagonist. But eventually, if I give enough drug, I can get to the same efficacy that I originally had. A non-competitive antagonist decreases the efficacy. It takes away some of the receptors, and you can't overcome this by giving more drug. That's it for our introduction to pharmacology. I hope this was helpful, and please do take some time to review these important concepts, and let me know if you have any questions. Thanks for your attention.